I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge topics, medical topics, to the Staten Island and tri-state community. Tonight we're going to be talking about medical residents. So if you think about it, when you go into a hospital, usually there's a junior doctor, an MD, someone who's trained, who's going to see you first with people who are attendings or more experienced or more older doctors usually, who've had more experience in the field. So we're going to talk about medical residency, and I have two wonderful people who are going to do it. So first I'm going to introduce the resident. This is Dr. Crystal Delp. She's a PGY3, which is postgraduate year 3. She's the chief resident, which is a big title, at Richmond University Medical Center in the field of internal medicine. So thank you for coming.
Thank you for having me.
And I'm going to have Dr. Jessie here, Dr. Jessie Saverimuttu. She's an infectious disease specialist, the chief of quality improvement at Richmond University Medical Center, and very, very involved with the medical residents. So we're going to talk about medical residency. And there are different words, intern, resident, and so many people, when they go to the hospital, and I think over the years we've been more conditioned there that a lot of people see you when you go into a hospital, to the emergency room, and even if you go to your community urgent care center, your primary care physician's office, that you're seeing a lot of people there. And in the hospital, sometimes people, the first person to see you, or one of the few first people to see you, are the medical resident. So when people go to see the medical resident, what should they expect? And should that be a comforting thing that someone who is usually younger, somebody who's just recently out of their training, and first of all, what is a medical resident? And should people feel comfortable being evaluated by someone who's a little bit younger, a little bit junior in stature to some of the senior people in the hospital?
Yeah. So to answer the first, medical resident is someone who's still in training. So we're under someone else. So we're under an attending. We always have supervision whenever we're seeing patients. So in my point of view, I think people, should be comfortable seeing residents. We are in the hospital 24/7. Like, you are always seeing us. We're in and out. We are very, fresh out of the books. We're wanting to learn. We're, doing all the things that we need, that need to be done for the patient, wanting to help still, just.
Yeah. So I can, as one of the attendings working in the hospital, I must tell the public not to be afraid. If there is a hospital with a residency program, that's really a plus, because there's always a physician there to take care of you.
So residents are MDs, DOs. They are licensed to practice medicine under supervision.
Under supervision.
Of course. But these are not students. No. These are not college students, high school students. Well, some people look younger and younger, but they're actually physicians who've gone through, completed their 4 years of medical school.
Yes.
And I think that's important for people to understand that. And Dr. Jessie and myself are teachers at a major hospital on Staten Island, so it's really a pleasure for us to deal with the medical residents.
Yeah, and at no time are they unsupervised. That the public should know, because the residents have to always discuss with you or with me according to a subspecialty. But the primary care physicians, they have to discuss with them, and they make a plan for the patient, not on their own. It's under supervision that they do it.
Yes, and we don't do anything without the consent, not only of the patient, first and foremost, but like our attending. So we're never going to go in and do any type of procedure without first running it by our attending, who also agrees that that's something that needs to be done for that patient.
So what is a patient, when you see a patient for the first time, and introduce yourself, of course, as your position as chief resident, what are most of the patients, what are most of their opinions of? Do they feel anxious? Do they feel comforted when you guys come in?
Yeah, I don't think I've ever had a bad experience where someone has said no, that they didn't want to be seen by the resident. Part of the benefit of having a resident is that I know it can be sometimes frustrating for the patients when you're seeing so many different doctors and having to repeat your story so many different times, but the benefit is that everybody has different life experiences, everybody has different backgrounds, so they're all coming in asking questions from a different point of view, so it gives more of a chance to get more information, more history, more things that might help you come to and establish a diagnosis so you can get on the right path for for the treatment for that, whatever it may be that they came in for.
And that's somebody knows about your case. You do. When I was growing up, they used to call it a sign out. Now it's an endorsement, where you tell everybody on the medical floor. You tell what their problem is.
Yes.
And the more people who know about the problem, especially at certain ungodly hours, 1, 2, 3 in the morning, so there's a doctor who's awake, alert, and knowing that about about your care is always an advantage to a patient.
Yes, there's always, if something happens on the floor, there's always at least one, if not two, doctors on the floor at night, always two, and then during the day there's even more. Not including the attendings. That's just us, like residents, all involved in the care. Plus, there's other doctors throughout the hospital. So there's always plenty of people available to help, and especially if there's something that emergently needs to happen.
So tell us about residency over the years. So residency over the years, first had this very much of a bravado of people who would spend 36 hours awake, and clearly we found that through very tragic circumstances where patients were sometimes not cared for it the best way, and the excuse of being tired really didn't help that person. So now tell me a little bit about the rules of residency now and people going home and being able to live normal lives and try to, and even for the patient in the hospital, being taken care of by somebody who's awake. And it sounds funny when you think about it, but there was a time when even when you were on call for many hours, a day or two, you really fell asleep many times. So tell us a little bit about some of the new issues and the rules.
The residency programs are governed by the ACGME, and over the years, like when I was a resident, 2003, we used to have 24-hour calls, but that was much better than 36, and long before that, that used to be 72 hours. So it was getting cut shorter and shorter, but we did like the whole day and the night, and we could go home only the next day. That was really tiring, and towards the end of the day, and thinking of being there the whole night, and you get called on a patient, you really cannot think clearly, and that is, as you said, detrimental to the patient. So that has been revised, and now they have different shifts. So the shifts that are carried out in our hospital is from, correct me if I'm wrong, 7 to 5, then 5 to 8, there is a short call, then from 8 to 7 or 8 to 9, there is the night shift. So there are 3 different shifts taking care of the patient in that 24-hour period, whereas we used to take care of the patient all that 24 hours. So that's a big shift, and that really should help the patients. What is important here is the handoffs, as you said. So these shift changings, every shift should be able to say, listen, this is my patient, this patient has this problem, please follow up on this blood work or do an EKG on this patient. So that handoff is very critical. So that's why ACGME requires us to train them to give good handoffs. So that's a trade-off here.
Absolutely. Crystal, let's go into, we're now post-pandemic. Thank goodness, and Dr. Jessie is an infectious disease specialist, and in conversations, there are less people with COVID-19 in the hospital now, less people who are getting very sick with it. But during COVID-19, the pandemic, you were one of the junior residents.
I actually didn't go through COVID.
You just missed it?
I missed it by like a year, yeah.
Oh, okay. I thought, but just towards the tail end. It seems like it was yesterday. Dr. Jessie would also. So tell us your experiences during COVID-19 with the residents, and really how. I want to sort of give a boost a little bit to those were times that even as an attending in neurology, the chief of the department, we would go in and we would see people very briefly during this very harrowing time. And the people who were in the intensive care unit, the infectious disease specialists, the residents and the nurses, of course, were the ones who were really giving most of the direct care. We would just ask questions more than anything else. And really, what did you think about with the residents and the nurses during that time?
Yeah, they were heroes. That's all I can say. You know, for everyone who worked during that pandemic, the immediate feeling was, this is our turn to be in the front line and give our lives. That's the way everybody worked. We know anything can happen to us because nothing was known about COVID at that time. Absolutely nothing. So us, and when I say the healthcare workers who went into work every day in, day out, during the night, they did not know whether they would come down with it. And also, they go home, and their families wouldn't know whether they would come down with it. But they did take that risk because there was a certain amount of pride in what we did. We just want to make sure that all our patients are safe. And there was that feeling of unity, the feeling of caring for one another. Through that disastrous period, that feeling actually was a beautiful feeling, and everybody did their best.
Absolutely. There was a tremendous cohesive unit at the
Yes.
hospital.
It didn't
And-
matter what you did there, but we all did it together. Like if someone had some food, they would invite, come eat with us. That feeling was so beautiful.
And also the sad situation of how sick the people were. Our patients were, families weren't allowed in.
Yes.
And things really were so sad. Hopefully we don't relive that whole process. So tell me about some experiences during your residency, and even some patients or anything like that. People who really have left a mark on you. You said you just missed the height of the pandemic, but I almost, not to say that you weren't there during the pandemic, but somehow even a year ago, I was seeing patients with COVID even last month in the hospital.
Yes.
So it might have been not at the height of when we were all masking up head to toe with all those space people suits, but even recently there have been so many people, and not just COVID, but just really about your residency and what you're going to decide to do in the future.
Yeah, I mean, sometimes you don't know why a case connects with you more than others. There's a handful of them over the whole residency career that I can pinpoint. I can think back about everything that happened with that case. Some of them are, good outcomes, and you're like happy to see the family go home, like the patient go home, and they like get better. And unfortunately, some of them are, the more negative ones, and the patient may not make it. But a lot of the ones that I remember the most are when I connected with the families and with the patient and everything, and just that feeling of we're all doing this together for the patient. Those are the ones that typically stay with me. Which is kind of what led me into wanting to do critical care, which is because that is more, because a lot of those patients might be intubated. They're the sicker patients, the ones in the ICU. You don't always get a chance to talk to the patient, at least initially when they come in, because they're that sick. But like the connecting with the families and the being there with the family and helping the family, go through that, what at that moment is the worst moment in their life, and being able to be there for them during that to try to help them get through it, whichever way it goes, to be able to answer the questions, to be able to help them understand, to be able to help them make the decisions that they need to do for their loved one. So that's kind of what led me down the critical care route. Also working with our program director, Dr. Fenoyam. He's an amazing man and an amazing doctor, and I hope one day to be half the doctor that he is. So just watching him do the things that he does with such ease, it's kind of inspired me in wanting to follow in his footsteps in that way. So yeah, I'm going into critical care and nephrology. So nephrology, critical care. So the kidneys, and then ICU.
It's so interesting how we've all had mentors in our life.
Yes.
I mean, I became a neurologist because of a mentor that I had. I don't know why did you become an infectious disease specialist?
From my small days, I used to love, looking at microbes. I had a little microscope, toy one. And I was fascinated by that, and I said, this is a warfare that I will not have any qualms about fighting to the very end, because we have to get rid of these microbes because they are waging war on humanity. So that kind of kindled my interest, that thought. But when I came to Richmond University Medical Center, which was then called St. Vincent's, we had an ID specialist who was such a kind gentleman, Dr. Omar Martinez. You might know him. Yes, and he did inspire me quite a lot to want to do infectious diseases here.
And that's why you always want your doctor to like what they're doing.
Yes.
And that we could talk about all the issues that physicians go through with getting authorizations and medicines and trying to do the best for our patients. But if you don't really love what you're doing, there's a problem. And every day when I wake up, I can't wait to go either to the hospital in the mornings and then my office in the afternoon and our MS clinic in the afternoon, really basically to see our patients, because it's a tremendous honor and privilege for people to come to ask of us to care for them. So that's really
Yes.
marvelous. So let's talk about a different hat that you have. You're the head of quality improvement at the
For
hospital.
the Department of Medicine.
For the Department of Medicine.
Yes.
Dr. Jessie, I can't say a word that I can't get through. Yes, for the Department of Medicine, you're the head of quality improvement. It's a whole mouthful. So actually, after that, explain to everyone what that means and why is that important? And again, even we're talking more about the residents.
Yes.
Because I've been to many of your M&M meetings, which will tell us about that, and really trying to teach. So you're teaching attending, such as myself. I learn a lot from you. I'm teaching.
Likewise.
Oh, thank
I
you.
learn from you.
Teaching, I learn from the residents, and actually I learn a lot from the medical students.
Yes.
They're the ones who really keep us on our toes. But tell us about quality improvement and the idea that if you go into a hospital, there are students there are nurses there, of course, there are residents there are all kinds of people. And how what you do for the hospital really helps people. And it's not just for us to have an exercise in thinking. I mean, we've been to a lot of events where I disagree with management, or I agree with management, and outcomes. So tell us a little bit, and tell really the viewers out there that there really are checks and balances in the hospital system.
Yes. So the first thing that I want to tell everyone is this, which I tell the residents. Treat the patient as your own family member. That's the key to everything. Show that compassion and love that you would to your own father, mother, brother, or sister. Once you have that in you, everything else will fall into place. Taking from that kernel, what do? There are different angles. The first thing is, if you want to see a patient, you have to create that rapport with the patient, that the patient trusts you. So what do you do for that? You go in, you introduce yourself, you tell who you are and what your function is in regard to that patient. And then make eye contact and make sure that patient feels comfortable with you. Once you have established that, then things will go smoothly. So that's the first step in the direct care of the patient. Coming to the real medical care of the patient, there are areas of quality that you have to be very careful about. The one thing, you have to make sure that you get the facts about the patient correct and discuss with your attending. That is one thing that we actually audit as a tool for quality for our department, that the residents have discussed with their attending the care of the patient. So they present the case to the attending and they are able to come up with a differential diagnosis and make a plan for that patient. Thereafter, you have to order tests. So make sure that you do not order unnecessary tests, that you do the appropriate
What
things
happens
for the
if you
patient.
order an unnecessary test?
That can lead to unnecessary usage of medications.
Right. And people stay in the hospital longer, they get infections.
Yes.
The test might take another day or two to come in. And our goal is, of course, top quality care, but it's also for people to go home as soon as possible.
And
to
reduce the length of stay. Right. And it has a lot of ramifications for the institution too. It doesn't do good because it goes into another area altogether. And having said that, we also must make sure that we do not cause any infections in the hospital for the patient. So central line infections, catheter-associated urinary tract infections, giving antibiotics leading to Clostridioides difficile infection, giving MRSA, all these things have to be taught to the residents. So that is part of the quality work that we do, that the residents are aware that these infections happen in the hospital, and if it happens, we are responsible. The patient did not come in with that. So they have to be aware of that and make sure they take all the necessary steps to prevent that happening to the patient. So these are a few examples. And then if anything does happen that's untoward, we do take those cases and discuss them thoroughly well to see where we could have done better. So those, we call them as morbidity mortality conferences and near misses, so that the residents, all of them together, sit down with the attendings, and you come in several times to help us out, and we discuss the cases and say, oh, we could have done this better, so the next time it happens, you know what to do. So these are a few examples of quality that we do in the Department of Medicine.
And that's crucial, of course. So tell me, and again, when we sort of look at the hierarchy from the first-year resident to the second-year, third-year resident, what kind of lines of communications are open right now, Crystal? Like, do the first-year residents feel comfortable calling the more senior people?
Oh yeah, absolutely. And even with regards to like, the different levels is we give responsibility in a stepwise fashion. It's not like someone comes in and we give them the ability to go and do anything that they want, So as an intern, you come in and there's certain things that you're allowed to do. You have to run everything by first-year senior, which is like either PGY2 or PGY3, someone who's been there a little bit longer than you, who then also in turn has to talk to the attending. So there's different levels of supervision throughout the whole training, day or night. And then as you progress in your training, from PGY1 to PGY2, you get slightly more responsibility. So then you don't have to talk to a senior resident, you have to talk to just your attending, and you having that back and forth and that conversation with them to be able to develop your plan and, treat the patients as needed. And then as a PGY3, so when you're another step closer to graduation, almost an attending yourself, usually you've built enough trust and enough experience that your attending is allowing you a little bit more freedom. You might not have to call them for like every decision, but you still have to discuss the cases with them, and it's more of guiding at that point and like lightly guiding versus like during the first couple of years, it's more direct, making sure that this test is ordered.
And the residents have to do a certain number of procedures before they're allowed to do them on their own.
Yes.
And everything from drawing blood, putting an intravenous in, things that you think are relatively straightforward before doing other more aggressive or more other kinds of procedures that we have with it. So let me ask you a whole different kind of question. And this, I have some strong feelings about apologizing. I seem to do it a lot, and whether we'll talk more on a benign level. Why isn't a test done this day? Apologizing that the scheduling didn't work, and even if it's not actually my fault, it's not the system. There's sometimes systems problems. What's your opinion, Dr. Jessie, about telling a family that something? With regard to different levels, I said maybe it's a blood test, maybe it's not getting the results of a test, maybe something even more.
Yes.
And discussing with the family what happened and going from there.
That is very important. So communication is key to trust. So if we establish that trust and the families understand this is what happened, they would be very willing to be with us and be able to make sure that the patient is okay. But if there is a loss of that trust, then after that it becomes a problem. So to answer your question, telling the patient or the family that this is what happened would really go a long way in helping the patient ultimately to get better.
I agree. Well, what do you think, Crystal?
No, I agree. As Dr. Jessie said, communication is the most important thing when it comes to a doctor-patient relationship, any relationship really, but the doctor-patient relationship, because the biggest cause of frustration for the patients and the families in the hospital is not knowing what's going on. So even if you go in and tell them, look, I'm sorry, your MRI that was supposed to happen today is not going to happen because there was an emergency case that they had to do, at least they know what's going on, instead of them sitting there waiting for 4 or 6 hours, not knowing what's going on, still expecting it to happen, and then it's still not happening. That's where if you just gone in the first place when you knew, and just communicate that with them, apologize, let them know that you're going to work on getting them rescheduled, that you are there advocating for them. So they know that you're communicating with them and you're advocating for them, and that helps with the whole doctor-patient relationship while the patient's in the hospital, because we all have to remember that these people, they're not feeling well. That's why they're there in the first place. So they want to know what's going on because they want to get better, because they want to go home and go about their lives. So we have to give them that extra compassion, as like Dr. Jessie said, treat them as if it was your grandma or your brother or your younger sister, whoever, your family member, because if you were confused and scared and didn't know what was going on, you're more likely to lash out if something doesn't happen because you're scared, you don't know what's happening. So just keeping that line of communication open with them, in my experience, short though it may be, in my experience does help go a long way.
And especially sometimes things that seem silly or not silly to people where someone doesn't get their breakfast because of a procedure. So
Yeah.
they're
Yes.
hungry.
Yes.
And I mean, that's a very difficult situation that we sometimes encounter. When a test is going to be done, could they eat, could someone not eat, and
Yep.
things of that nature. So tell me, where do you think the future is? So if I asked you 25 years ago when I was finishing my residency, did I think that the way things would be, I would have been surprised. You know, there's always a lack of physicians. The idea of that us working 36-hour shifts, I never thought they would ever cut them down. And again, there were a lot of reasons because of some bad outcomes that was forced upon the world, which I think, thank goodness, that's a great thing. Where do you think residency is going to be in the next 25 years? Any thoughts?
I am not sure with this AI thing, so where we will all end with that. But by and large, human beings have to be there, to be with patients, touch them, analyze what's the problem with them, give that care, give that compassion, which nothing else can do. So basically, it has to remain the same.
And I'll ask Crystal about AI, because that's actually what I was getting at right now, is you're, I'm sure, a lot closer to it as some of my kids are. The idea about the need for a physician. Do you think, especially we learned a lot during the pandemic about virtual medicine. And there's nothing I really don't like. I don't like more than that. It's very difficult, and we say it almost in a loving way, and we'll say it in this way. As an infectious disease doctor, your sense of smell is as
Yes.
important as anything else.
Yes.
Smelling certain kinds of infections, and it sounds funny to the public, but
Yes.
it's very true. When you walk into a room, you could smell certain
Yes.
things that are very important.
Yes.
And having virtual visits really hasn't helped. As a neurologist, there's an entity where sometimes people take medicines for psychiatric problems, not even related to this, and they have twitches. And there are some new wonderful medicines for this, something called tardive dyskinesia. And you can't tell if the virtual medicine is just up here.
Yes.
Maybe you're lucky and you see something. But most of our patients are all back now in the office, and we're seeing them. So what do you think about AI? And
I mean, I think it's a great tool in its place, but I think it is that. I think it's a tool for us as physical human doctors to use because, as you said, there's even just walking into a room and looking at a patient, there's a lot you can tell. You can tell their countenance. For you, if someone's one side of the face looks off or they're not using one arm more than they're using the other, like there's a lot of like visual clues that you can see as a person with experience. As you know, the more experience that you have, the easier it is for you to pick up those things that might not, for someone else or a computer or whatever, might not be able to pick that up as easily as one of, like someone walking in and seeing it can.
it's like Dr. House.
Yeah.
Looking at the pictures on the side, looking at everything, seeing the whole picture.
Yeah.
I want to say thank you. And we took a topic about residency and try to make it more human so that our community and our people and our patients and our viewers will really know and take the fear out of it. So I want to thank you both. You've been wonderful guests and have a wonderful evening. Good
Thank
night.
you.